Are you wondering if you have a blood clot right now?
Right now you could.
Watch this video and we're going to teach you what a blood clot is.
Okay.
And what to do if you got one.
Okay, I like it. Welcome to Talking with Docs. I'm Dr. Brad Winnie.
I'm Dr. Paul Salzal.
Okay, so our blood's normally liquid, isn't it?
Blood's really cool.
Right.
You know,
okay.
blood is an organ. It's actually an organ. It's your only fluid organ.
Okay.
No other organ can float around your body like that, right?
Nope.
Otherwise, I'd be saying, hey, Brad, your kidney's up by your cheek. You better push it back down to your flank. It doesn't happen. Okay.
Dad jokes so early.
Blood is a fluid organ, right?
Okay.
It's in your body. It's floating around. It serves purpose.
Right.
Carries oxygen, carbon dioxide.
Yeah.
A big part of the immune system.
Yeah.
Carries a lot of immune modulators to parts of your body.
Is it ever normal for our body to make a clot?
Regulates pH, regulates temperature.
You're not done
big
yet.
things. No, I wasn't done.
Okay. I like it.
And blood is cool because if you cut yourself, you don't lose all your blood.
Right.
It clots. It has to clot. This is an incredible way of clotting. Now, some people have disorders where that doesn't work so good, and they are at risk of bleeding. That's another video.
Yeah.
But in general, your blood is so smart that it'll stop itself from leaving your body.
Okay.
Exsanguinating. It does that through the clotting pathway, okay?
Right.
There's the intrinsic and the extrinsic clotting pathway. You gotta know about this if we're gonna talk about blood clot.
Go med school on me.
Don't give me that face. We gotta talk about it.
Okay.
All right. So intrinsic, extrinsic. Right? Intrinsic pathway is triggered by inside the vessel. There's some damaged collagen in the cell and the vessel wall triggers the intrinsic clotting pathway.
Yep.
Extrinsic clotting pathway is triggered when blood goes out of the vessel. See some tissue factor, it starts to clot, and they both converge in the common clotting pathway.
That's what makes a clot.
All right, don't forget about platelets.
Don't.
They also contribute to.
It's a critical part. If your platelets don't work, you're not going to make a clot.
Okay, so
But
that's,
sometimes we make clots in a pathological way.
things go haywire.
Right.
That is what we're talking about now. When this normal system in your body of coagulation or blood clotting goes wrong.
Right.
When good times go bad.
Right, and so clots can form in the arteries or the veins. So just quickly about the arteries, because that's really not the focus of this. So when you get a clot in your artery, that goes down those vessels and usually gets stuck in a smaller vessel because it goes from big vessels to smaller vessels.
Yes.
And this leads to if it happens in your heart, it causes a heart attack. If it goes up your neck into your brain, that's what causes a stroke. If it goes down into your legs, it can cause an ischemic leg, it can cause you to lose your leg. If it goes into your abdomen, and something called your superior mesenteric artery, you actually have damage to your bowel. You can even, your bowel can die. So it essentially causes like a heart attack of whatever part of the body it goes to.
Infarcts. These are called infarcts.
And this often relates to little plaques, atherosclerotic plaques, or even clots that form inside of the heart because of an abnormal rhythm like atrial fibrillation, and those have very specific consequences. We're not really talking about that today. We're talking about the veins. And the main thing we talk about in the veins is the deep vein thrombosis, or the DVT. This is something that people are familiar with. What is a DVT, Paul?
A deep vein thrombosis can happen in your arm, your upper extremity, or your leg, your lower extremity. In our business, it's more common in the lower extremity after we've done a hip replacement or a knee replacement. But it's where a clot occurs in the venous system. Remember, arteries carry the blood away from your heart. Veins bring the blood back to your heart. So you clot in that area.
Yes.
Now you're on the right side of the circulatory system. There's the left side, which is that high pressure. We're on the right side. So instead of infarcting some tissue, right, the blood's already gone to the tissue, it's trying to come back, you have this clot. If a piece of that clot breaks off and goes to your lungs, then you can have what's called a pulmonary embolism.
Okay.
That's the big complication of a DVT. There are other complications. You can get phlebitis down the road, chronic venous insufficiency and that, but those are sort of later, less severe complications than the acute, immediate pulmonary embolism, which is, in some cases, fatal.
Right, so let's pull it back a little bit. So very, very common, 1 to 2 per 1,000 people. DVTs are very, very common. Okay, so who gets them? What is a risk factor for a DVT? Because there's some relatively well documented and well known ones.
There's some things here you wouldn't even guess were a risk factor. So definitely after a major orthopedic procedure. That's our biggest sort of one that we see.
100%.
Right?
I would agree with, and even any lower extremity trauma particularly.
Yeah. Smoking, that culprits, everywhere. That causes just about everything. So smoking.
Increased risk with things like obesity and cancer.
Cancer, that's the tricky one you wouldn't really think, right? And sometimes the cancer diagnosis
comes after the blood
is
clot.
Initiated by the blood clot. Look at this person, he's got no risk factors, all of a sudden he has a blood clot. Then you start investigating, it's like, oh my God, there's a cancer going on somewhere in the body.
I'd say the other big one is either a family history of blood clots, so maybe your family has genetics that lead you to have a clotting disorder, or a personal history. So if you've had a blood clot, you have a higher risk of getting another blood clot, particularly in the first year after that blood clot.
Yeah. Other ones include like injury.
Yep.
You have post-injury and you have period of immobilization. And here's the other one that might catch you off guard is a long plane ride or a long drive, right? Hey, the good news is I made it to England. The bad news is I got a blood clot, right?
Bad news.
Any long flight, long drive, that can lead to.
Okay, so what do people experience when they have a blood clot? What are some of the symptoms that you're going to have?
Okay, so let's talk about, well, it could be upper extremity or lower extremity, but it's going to be
talking about lower.
Pain is one thing you're going to feel.
Yep.
Swelling, you're going to see, and dysfunction. Disuse will be difficult. You'll have pain when you walk.
Some warmth and redness.
Warmth, redness, warmth to touch, redness.
But you also could actually not have any symptoms.
Could be asymptomatic.
Yes.
Sneaky.
Makes it trickier. So, A, if you have any of the risk factors. B, if you have any of these symptoms. Now you're like, okay, I want to go to my doctor.
But then again, if an asymptomatic DVT, sometimes we discover that because you've had a PE, a pulmonary embolism. Right. Those things are characterized by chest pain, shortness of breath, high heart rate. I remember that question on the board exam. What is the ECG finding for a PE?
Sinus tachycardia.
Right?
Yeah.
And I didn't think of it because I think of tachycardia as a clinical sign.
Yeah.
And you don't really think of it as an ECG finding. But
right.
Lo and behold,
I think they're targeting the sinus part maybe. Okay.
Maybe.
So now you have some of these symptoms, have some of these risk factors, whatever. You're worried that you have a DVT. Mm-hmm. You go to your family doctor.
Right.
They do a good history and physical, and they tease out all those things.
Yeah.
What do they do on physical exam to assess it?
Like any physical examination, we always start with inspection. So you look at the limb. Whoa, that looks red. That looks swollen. We palpate. Ooh, that's warm to touch.
Right.
Firm swelling. Oh, the other thing about the swelling is it's often unilateral. Right. That's a big distinguisher. If you have redness, swelling in both your ankles or both your lower legs, maybe you have like really bad luck and you have two DVTs. Less likely, more likely, it's a systemic cause that's causing that bilateral swelling.
And one way to check this is actually to measure it. So I'm like, well, how am I going to measure it? Even if you just take a piece of string, go around your calf, and on the same part of your other calf, put it around. And if it's not the same, one calf is bigger than the other.
There you go. Taylor Brad has the answer.
Yeah. Okay, so your family doctor does that stuff. Can they confirm a DVT on physical examination?
No, I don't think that's. There's some things you can confirm on physical examination, like a tendon rupture or something like that, but not so much this. So we need some investigation.
X-ray?
X-ray's not going to help you.
No.
Okay. Here is where ultrasound is going to help you.
We do have a lot of negative views towards ultrasound commonly around the knee, but I would totally agree with you. I totally agree. And ultrasound is I'd say the gold standard. 95% successful in identifying deep vein thrombosis.
Right.
It's a very, very good
for
test.
that. And then you can also do some blood work called a D-dimer to look for remnants of clotting activity.
Trouble with D-dimer is that it's very sensitive. It's just not very specific. It can go with other injury or inflammatory conditions. So D-dimer is not very specific. And then if you're worried about the pulmonary embolism, you do a chest x-ray. Often a chest x-ray is going to be normal. You're still going to do it. You're going to do an EKG. Well, that's not going to confirm it. But there is a test that's going to confirm it.
You can do a CT pulmonary angio.
Yeah, and what it shows is that little blood, all the blood's going to your lungs, all of a sudden it just stops because that vein has stopped the flow distal to wherever it got stuck. Because as the vessels get smaller and smaller, that clot gets stuck.
Right. That's the chest pain, shortness of breath, tachycardia, and that can be fatal. That's why it's important to identify the DVT and even more important to identify the PE.
One little side note about the calf pain, I'd say the two injuries that I see most commonly that kind of masquerade as a blood clot, and you still have to make sure that it's not a blood clot, would be the calf tear, like the gastroc tear. I have a lot of people who get gastric tears and their leg gets swollen,
usually
they can't walk.
A history of trauma will
right,
help distinguish that.
But we just said that trauma is a risk factor for a DVT. And then I'd say the other one is the ruptured Baker cyst, where the cyst in the knee breaks, it tracks down the back of your calf, so your calf's swollen, it's really sore, it's bigger than the other leg. And so these are things to be aware of and that your doctor would assess.
I would say the most challenging one for me is just normal post-op swelling. After a knee replacement, you've got pain and swelling. And then you're trying to distinguish, is this just normal pain and swelling, or is this indeed a DVT? Not that long ago, everybody, remember we used to admit patients?
Routine ultrasound.
Everyone had to get an ultrasound before they went home.
I think it's because they stayed in hospital so long too now. Like it takes time for it to develop. But I totally remember that. Okay, so now you've confirmed you have a DVT. Now what's the treatment? You just kind of walk it off?
So the DVT can be, it's kind of, we distinguish it in two ways. Is it below for the lower extremity ones, is it below the knee or above the knee?
Okay.
It's below the knee. It's in the smaller caliber vessels. Those are smaller veins, so the risk of PE is much lower. So unless you have other risk factors like cancer or an active clotting process, or you've had a lot of DVTs before, something like that, often those just need observation and a repeat ultrasound in about a week or so. If the DVT goes above the knee, those are the bad actors. They can break off and go to the lungs.
Or you can get bigger.
Or even progress. Those we generally treat with an anticoagulant.
Okay, so the anticoagulant, that breaks up that clot?
The anticoagulant doesn't really break up the clot.
No, but I think a lot of people think that it does.
Yeah, no, that clot's there, and the way you're going to recover from that is your body's going to make collateral vessels around the clot, but that takes time. The anticoagulant is going to stop the chance of that progressing and reduce the chance of that becoming a PE.
Right, so you're on it for like a week?
No, you're on it for like a good 3 months, right?
Yeah, or maybe 6, or maybe a year, depending on your various. Some people end up on it for life, particularly if they have a very bad clot that had a PE and there's no identifiable cause. Sometimes you're on it for life.
Or an underlying coagulopathy that puts you at risk for DVT.
Okay, so any other things that people would do if they have a DVT other than the blood thinner? To help deal with the symptoms?
Sure, we even less invasive than a blood thinner, compression stockings, treating them symptomatically.
Very hard to get on. We have a video about that, but they're hard and uncomfortable.
They're tricky. Very useful in this setting.
Totally agree.
And then you could actually, like in some cases, although I've never seen this done, is if the clot is really big and progresses quite high up the tree, you can have it like removed surgically or endoscopically, sort of with an endovascular procedure.
Okay, so now you know what a clot is, you know how to identify one, now you know the treatment that's involved with it. Is there any way to prevent a clot? Like really, that's what people are here for. Like they say, I don't want a clot. I don't want to get one. How can I prevent it?
It kind of depends on what risk factors you have. And that's the most common thing is surgery, right? So so we recommend early mobilization. Compression of some kind. And just be super vigilant about the signs and symptoms of it by watching this video. For surgery too, debatable is some form of prophylactic anticoagulation. And we as a medical community have not settled on what the right approach for that is, so there is some variation from one surgeon to another, from one hospital to another.
That everybody says you have to have something?
Something, I would say, everyone's doing something. That something can range from like aspirin to one of the direct oral anticoagulants. Okay, some of the newer anticoagulants, or Coumadin, which is warfarin, which is rat poison basically, or injectables. Any one of those things you'll find across North America even, variation about what to do after major orthopedic surgery to prevent blood clot.
For the flights of the car, what I'd say is regular breaks, go for a walk, do the calf exercises while you're there. The evidence actually for compression stockings or taking a preventative baby aspirin actually is not very robust, and most people would, like the Heart Association, would not recommend it. So that's a very specific and unique conversation for you to have with your doctor if you're worried about that, but mostly just getting up and moving around. And there's actually been some studies that have shown that asymptomatic DVTs are very common when you have flights greater than 4 hours. So you just have to be aware, get up, get moving.
Especially where I sit in coach.
There you go.
Where you're cramped back like that and your knees are up near your ears, and then the person in front of you puts the seat back and now your knees go farther back. So, and the other thing is smoking. Obviously stop smoking if you are smoking. Here's another reason to stop smoking.
There you go.
Wow.
Leave a comment. If you've had an experience with a DVT, know someone that's had one, PE, whatever. Share your strategies on how to prevent them. And if you like this video, please like it, subscribe to our channel.
We try not to make this video too long so as to not put you at risk for one. But remember, you are in charge of your own health.
See you next time.